no headphones maybe.
So welcome everyone to today's spring webinar of the NIH Behavioral and Social and Economic Health Impacts of COVID-19 grant results. Apologies for the slight delay. There was a bit of a Zoom issue, as I think everyone's probably familiar with these days. Next slide. There we go. Next slide. I think we have some housekeeping issues. I just wanted to mention a few ground rules before we start with our introductions. All attendees are muted until 4:15 when we start the virtual networking. For any questions about the webinar itself, technical difficulties, etc., you can email or chat Sarah Johns directly using the Zoom chat feature. For any questions you have for a presenting PI, please use the Zoom chat and make clear to whom you're directing the question. So for example, if you had a question for me, what does SBE stand for? You'd put it that way in the chat. If you have a question for multiple PIs, please also make that clear. Feel free to send in questions at any point during the webinar. Some will be answered during a live chat Q&A at the end of each session. Sometimes we might have to have them answered in the chat instead of verbally. Please check the chat from time to time to see if your question was answered. Next slide. This is our agenda today, which everyone should have. I'm not going to read it out to you. Everybody should have that though. We're going to have a welcome in a second from Dr. Shannon Zank, the director of NINR, and then we'll have a brief presentation about the SBE Coordinating Center. Next slide. And without further ado, I'd like to have Dr. Shannon Zank provide our introductory message. Thank you so much, Dr. Zank.
Thank you, Dr. Spots, and good day to everyone. Thanks for allowing me to provide a few introductory remarks today for this extremely timely and important virtual event on NIH's Social, Behavioral, and Economic Health Impacts of COVID-19 initiative. For those who might not be familiar with just how extensive and important the SBE effort is for NIH, let me add some context. Leadership and committed staff of 5 NIH institutes, centers, and offices led the initiative's development and implementation. These are the National Institute of Mental Health, the National Institute on Aging, the National Institute on Minority Health and Health Disparities, the National Institute of Nursing Research, and the Office of Behavioral and Social Science Research. And the COVID SBE initiative involves a broader consortium of 21 NIH institutes, centers, and offices that have pooled funds to support this crucial research initiative. Over the past 2+ years, the development of vaccines and therapeutics have been biomedical triumphs. But the pandemic has also revealed how essential the social and behavioral sciences are for promoting vaccine acceptance and uptake, adopting effective behavioral mitigation strategies, and for understanding the short and long-term social, behavioral, and economic impacts of the pandemic. So this is where the COVID SBE initiative comes in. As the co-chairs noted in a recent blog, the SBE initiative will continue to contribute meaningful data to support not only the current pandemic response, but also provide evidence to support an enhanced response to future pandemics and large-scale public health crises. Across the SBE COVID initiative, there is a keen emphasis on addressing the pandemic's impact on populations with health disparities and those with medical and social vulnerabilities. Towards this end, the SBE Executive Committee, of which I'm a member, issued 4 funding opportunity announcements that have already resulted in 37 funded grants, with more under consideration, and also funded more than 50 just-in-time administrative supplements. You'll be hearing more today and tomorrow about some of the emerging findings from many researchers funded through the SBE initiative. At NINR, we are committed to supporting research to understand the social, behavioral, and economic impacts of the pandemic. And importantly, to learn what policies, programs, and interventions were effective in mitigating these adverse impacts on health and health equity. Such research is consistent with the perspective that nursing science brings to the biomedical enterprise, a perspective that recognizes that health must be addressed in the context of people's lives and living conditions. I'm proud that NINR has played a key role in supporting and funding COVID SBE grants. Through the SBE Data Science Initiative, these include a national neighborhood data resource to understand inequities in COVID's health and socioeconomic impacts, research on COVID spillover effects on cardiovascular disease in rural populations, and research on how neighborhood and school resources exacerbated or mitigated health and educational disparities during the pandemic. Through SBE, NINR has also supported intervention research aimed at improving the health of transit workers and COVID-19 survivors and their care partners, addressing COVID-related barriers to pain care in rural populations, and improving nutrition, physical, and psychosocial functioning in underserved older adults. Other NINR-funded SBE studies are examining the impact of delayed acute and chronic care during the pandemic and testing models of care that address social needs. In still other research, investigators are exploring the roles of community health workers and community health centers during the pandemic. Related to SBE, this past winter, NINR released an RFA to understand the impact of pandemic-related food and housing policies and programs on health and health disparities. So I often say that to me, success is making a real difference in people's lives, their living conditions, and in their health, while ensuring no population is left behind. By generating much needed evidence, everyone here today is poised to make a significant difference in the lives of those disproportionately affected by COVID-19. So I can't thank you enough for all the work you've done and continue to do to protect the most vulnerable among us from the most damaging effects of the pandemic. So thanks again, Dr. Spots and your team for all your work in coordinating this event. I'm excited to learn more about the outcomes of NIH's COVID SBE research. So I'll turn it over to you, Dr. Spots, to get today's session started. Thanks again.
Thank you so much for that wonderful introduction, Dr. Zink. We really appreciate it. Next slide. So I just want to quick go over some meeting objectives and a little information about the group that put this, this webinar together. So today we want to be able to identify, communicate, and document key findings. We want to really increase collaboration among these different SBE teams by sharing lessons learned, provide a forum for discussion between researchers of similar interests, and provide a space for SBE leadership to communicate their efforts, reflections, and hopes for the future. Next slide. So this, all of the research today came out of an NIH-wide COVID-19 SBE initiative. Our goals were to assess the social, behavioral, and economic impacts of COVID-19 and its mitigation efforts, and to improve our response to the current pandemic and prepare more effectively for future infectious disease epidemics. Some of our priorities were to look at the effects of various mitigation strategies and the role of adherence, to look at the social and economic impacts of various mitigation efforts, to look at the downstream effects of these impacts on mental health, suicide, substance use, and other disorders, to look at the effects of the pandemic and its mitigation on healthcare access and health outcomes, and to look at the effects of interventions, including telehealth and digital interventions, in reducing these impacts. And these 2 days are designed to really highlight some of the research that came out of this, this working group and the work that has been funded through it. Next slide. This is kind of our SBE organizational structure. You can see across the top the executive committee, and then there were 2 subgroups, a data science subgroup and an intervention subgroup. And each of those had different goals, obviously, and we'll see the results of that work today and tomorrow. Next slide. Dr. Zink discussed a lot of this, so I won't belabor the point here, but we did have a lot of institute centers and offices represented. We funded a lot of grants and supplements, at least 60 grants and supplements through this program. And as you'll see again today and tomorrow, we've had hopefully some very impactful research come out of this work. Next slide. One of the projects that came out of the SBE Trans NIH work group was the SBE COVID Coordinating Center. And now I will turn that over to Dr. Levenstein so that she can give a brief overview of the work going on there. Dr. Levenstein?
Thank you very much, Dr. Spotts, and thanks to everyone at NIH for organizing this and to all of the researchers who are contributing to this important work. I'm really pleased to be able to talk to you today about the new SBE CCC COVID Coordinating Center, whose job it is to foster collaboration across SBE COVID research. Next slide. So this project is a collaboration between NIH, which is funding it, and it is hosted at ICPSR, the Inter-University Consortium for Political and Social Research, at the Institute for Social Research at the University of Michigan. And what we're doing is building a nexus, a place where a virtual place where people can come together to communicate and collaborate among NIH-funded projects that are undertaking social, behavioral, and economic research on COVID-19. We aim to promote an innovative, inclusive, cross-disciplinary approach to COVID-19 research across the behavioral and social science community, multiple NIH award recipients, and the broader public. Next slide. I want to introduce to you the other people who are part of the COVID Coordinating Center, because we are really here to work with you. So there's me, Maggie Levenstein, my co-investigators, Jim McNally, who leads the aging archive here at ICPSR, and Amy Pienta, who leads the drug abuse and tobacco abuse and HIV archive here at ICPSR, and Megan Chenoweth, who is the project manager for SBE CCC. We will also have an additional investigator joining us on July 1st, John Kubali, who is a recent PhD. She recently received his PhD and has been studying COVID in Nicaragua, is going to be joining the team as well. So you will get to meet him very soon. We're really pleased to have him joining. Next slide, please. We also have other partners who are available as resources for you and for the center. These are other partners based at the University of Michigan. They include the people in survey methodology and the Survey Research Center at ISR, who are there to help do consulting on data collection and survey design for those people who are engaged in that. We're also working closely with the Program for Research on Black Americans, which is part of the Research Center for Group Dynamics at ISR here at the University of Michigan, to make sure that we are engaged in intentional outreach and inclusivity in the way that we're doing both data collection and undertaking our research throughout all of the research that NIH is doing around SBE COVID research. And finally, we're working with the Center for Healthcare Research and Transformation, CHRT, which is going to be helping, really especially helping with communication strategies and helping to make sure that the broader public understands and is aware of the important research that is being undertaken as part of this initiative. Next slide. Finally, I want to introduce you to the NIH program project staff who are working with the coordinating center. They are in John Phillips, who is the program officer from NIH, and Partha Bhattacharya, who is a project scientist for the SBE CCC. Next slide. Next, I'd like to tell you a little bit about the 8 projects that have already been funded. So let me just back up a little. So the coordinating center is based here at the University of Michigan, and we are supporting NIH research all across the United States in this area. There have been 8 projects that are already funded and that are part of the consortium that the coordinating center supports. We expect to have a number of other research projects funded in the next weeks and months that will also be joining the consortium. As was previously mentioned, there's funding from each. I think there are 7 different NIH institutes funding these 8 different consortium members, and they address a range of problems across the social and behavioral sciences. So the National Institute for Nursing Research is supporting a team that's based at New York University studying children's longitudinal health in New York City, working closely with New York City school data. OBSSR is supporting a team based at the University of California, San Francisco, that's studying county level COVID-19 related public health and social policies, the impact on racial, ethnic, and socioeconomic disparities in mental health and healthcare utilization. The National Institute of Aging is supporting a team based at Harvard and Mass General Hospital, studying the impact of COVID-19 pandemic on patients with Alzheimer's and Alzheimer's disease-related dementias. NICHD is supporting a team that is based at the University of Minnesota, studying unequal parenthoods, population perspectives on gender, race, and sexual minority disparities, and family stress and health during the pandemic. Next slide, please. NIMHD is supporting a team based at the University of Southern California, looking at COVID-19 mitigation efforts and disparities in terms of access to routine preventative care and chronic disease management. NIDA is funding a team based at Syracuse University, studying state COVID-19 mitigation policies and the implications for psychological health, drug overdose, and suicide. NIA is supporting a team based at Ohio State that's studying the health and economic impacts of COVID-19 and policy responses. And NIA is also sponsoring a team based at the National Bureau of Economic Research that is building a new database to measure the association between income, race, and mortality, inequality, and longevity during and beyond the COVID-19 pandemic. So you can see these projects address a range of both data creation, data collection, studying things at the very local county, state, and national level, and with an emphasis on the different aspects of health that COVID has unfortunately impacted all of. Next slide, please. So what is it that the coordinating center is going to do to support these projects, other projects to be funded, and the work that has already been done that many of you are going to be talking about today? So you can think about what we're doing as addressing 5 different buckets: research and collaboration, guidance and support, pilot projects, an annual meeting, and a website and dissemination. And you'll see at the bottom of each of my slides is the link to the website. I hope that when this is over, you will go check that out. Next slide, please. So probably the central thing that we're doing is supporting research and collaboration among the consortium members and between the consortium members and others to make sure that we have an inclusive and diverse research community engaged in addressing these important topics. So why is this important? These are, as we know, everything about COVID and everything about science and health has become contentious, and in order for us to have high impact research and that people understand both the impacts of COVID and on the public health and on the effectiveness or the lack of effectiveness of different policies and interventions and behaviors and ways of thinking about COVID, we need to be able to be transparent and reproducible with the broader community so that people can have trust in the research that you all are undertaking, can understand what it means, and that research can build on one another. The work of the SBE CCC Coordinating Center is really to help support that. So collaboration and sharing of key concepts and measures of interest. And one of the simplest, of course, is something like a mask mandate. Well, what does a mask mandate mean? What does it mean when it goes away? If we all are measuring these things in an infinite number of ways, which is perfectly plausible, it makes it very hard for us to compare and draw conclusions from, inference from what we say about the impact of a mask mandate or masking behavior or mask recommendations or mask policies. So if we can share those key concepts and share how we're measuring those key concepts, we can really encourage comparability and transparency in the research that is being undertaken in this area. So we want to share those concepts and measures. We want to collaborate and share survey instruments, other kinds of survey and biological, other kinds of measures where people, administrative measures that people are collecting to make sure both that we are efficient, we're not wasting resources that are so precious in this urgent period, and that we're doing science that builds on one another. If somebody learns something, we'd like to be able to build on that and do something better instead of constantly reinventing the wheel about how we measure things. So sharing those instruments, sharing methodology, not to require that everyone does the same thing, but to make sure that we're learning from one another in terms of best practice, in terms of what actually works in engaging with communities and learning from communities in terms of creating measures that are comparable. And then we want to crystallize that learning, the practices that we're engaging, and share them with the broader community as common data elements. As many of you know, the National Institutes of Health, and particularly has focused on the development of common data elements with collaboration from across the institutes to share how they're measuring different things. We want to put these SBE concepts and measures, policies into common data elements so that they're available and shared not just among the 8 or a dozen or 15 or 20 researchers funded under this mechanism or everyone participating in this workshop today, but also among future scientists so that we build on this. Again, and we do that, the common data elements is there to help support that kind of transparency and reproducibility in research. Next slide, please. In addition to supporting this kind of research and collaboration around measures, we're also engaged in guidance and support, particularly around supporting data access and data sharing, but also technical and policy guidelines, best practices for ethical data. Again, we want to make sure that people are understand, for example, the new NIH data sharing policy, and so that they're able to share their the data they're using in their research in a way that is responsible to the people who are in the data and to the rest of the scientific community. And we want to make sure that people understand how to do that both for non-sensitive data and for sensitive confidential data. We're also providing technical assistance and guidance for the design and implementation of data management plans and the coordination and collection of common data elements, as I mentioned. Also really helping people get access to sometimes administrative or other data that can be very hard to access, making sure that people have secure ways to analyze data when it is confidential and understand best practices in doing this, providing relevant resources to increase the discoverability of NIH-supported SBE data resources via our site. So if you can look for ideas about data resources on our site and on links from there, and then also to provide guidance and support for best practices in doing data linkage so that the resulting data sets that are analytical data sets do not exclude people who sometimes get missed during linkage processes. So that's when we don't want to make people disappear just because we're using because we're not paying attention when we create record linkage. So that is a priority for us. Next slide. The coordinating center will be supporting pilot projects. We will solicit and award pilot projects. In fact, we already have solicited and awarded 3 pilot projects, and we expect to be supporting additional pilot projects in years 2 and 3. These will create opportunities for new collaborations across the different SBE COVID-19 projects. As you saw, people are in just those 8 that I mentioned, as well as those that were mentioned before. And as you'll see all day today, people are taking different approaches and collecting different kinds of data to study different ways that COVID has affected the population. And we would like to create conversations and collaborations across those projects. We also want to bring in younger scholars, younger scientists, scientists from underrepresented backgrounds into these studies to make sure that the people who are being studied are represented in the scientific community that's studying them. So those are priorities for the pilots. The pilots are intentionally going to emphasize integrating using SBE common data elements into research projects and focus on the study of health disparities and vulnerable populations. As I said, the first 3 pilots were just awarded, and we expect to have more in the next 2 years. We will have an announcement in the fall of 2022 about the process for applying for those pilots. That information will be on our website, also disseminated through various kinds of social media. So please keep an eye on the website so that you hear about that. Again, the goal is harmonization, comparison, and inclusion, right? Next slide, please. Let me just give you a shout out to the 3.
Wrap up in the next 30 seconds.
Shout out
or
to
so,
the
please.
3 pilot projects that have been funded are right here. Why don't we just go ahead to the next slide? We also, as I mentioned, will have an annual meeting where we will give researchers a chance to present their results and again, think about how to work together and how to promote collaborative and effective research on SBE and COVID-19. Next slide. And then last, please do take a look at our website that will allow you to see everything I just said and a lot more. We're really trying to keep it as up to date with new resources about related data that will be of interest to people working in this area. So thank you very much. And then I think next I turn things over to Laura Quacco from NIAA to start the next webinar or next discussion.
Absolutely. Thank you so much, Dr. Levenstein. I'm Laura Quacco, Program Director at NIAAA, and I will be moderating our first main session on mitigation efforts. And excuse me, I'm delighted to introduce our first speaker, Dr. Santa Maria. Take it away.
Great. Are you able to hear me okay?
Yes.
All right. Thank you so much, Dr. Quacco. And thank you everybody from the SBE team for this opportunity to present today. Today, I'm going to be presenting some preliminary data on COVID-19 infection and the presence of antibodies among a sample of young adults experiencing homelessness. Next slide. So before we get started, I want to talk a little bit about homelessness in general. On any given night in the United States, about 1.7 to 2.5 million young people under the age of 25 are experiencing homelessness. That's roughly equivalent to about 1 in 10 young adults age 18 to 25 and 1 in 30 adolescents age 13 to 17 will experience homelessness in a given year. So we know the tumultuous experiences of daily life on the street can be incredibly difficult for young people experiencing homelessness. So while surviving the dangers of the street and trying to meet their basic needs for food and shelter, they experience great difficulties in maintaining their health and well-being. Issues unique to homelessness, such as lack of shelter, low access to hygiene and sanitation, as well as transiency need to be considered when we're considering how to best meet the needs around COVID-19, both infectivity and outcomes. They're a highly vulnerable population whose circumstances put them at great risk for COVID-19, but then also for experiencing poor health outcomes if they do get infected. Congregate living situations such as shelter, halfway houses, encampments, and street dwelling make it really challenging to access basic hygiene facilities, as well as to have access to any of the mitigation strategies such as masking and so forth. They're also a very transient population, geographically mobile, and that can make it very challenging to track and prevent transmission when it is detected. As well, while many cities have imposed stay-at-home orders to prevent COVID-19 transmission, those without shelter were largely left behind on the street or without access to resources as shelters closed and drop-in centers and food distribution centers closed. We don't really know what happened to young people during quarantines and during these lockdowns. And it's also unclear what the impact of the lockdowns and infection mitigation strategies have had on young people's mental health, substance use, and housing. We know that they experience mortality rates that are 5 to 10 times higher than the general population. And we're afraid that COVID-19 may have made that even worse for them. Next slide. So we are conducting a current study. It's a waitlist controlled, randomized controlled trial to determine the efficacy of a nurse case management HIV prevention intervention compared to usual care for young people experiencing homelessness that are between the ages of 18 and 25. In this study, we're enrolling up to 450 young people, and we're following them for up to 12 months. Next slide, please. So again, in this study, we're enrolling 450 young people, following them up for 12 months. And young people are being recruited from shelters, drop-in centers, clinics, as well as street outreach efforts. Next slide. To address some of the gaps that we're seeing with COVID-19, we propose to have a mixed method study that's utilizing the existing cohort from that R01 to be able to follow young people up and see what's happening. So in this study, we're going to be enrolling 268 participants. We'll be conducting qualitative interviews on 40 of those young people, and as well as looking at prevention measures and how it's affecting daily life, health, and inquiring about COVID-19 knowledge of adherence to prevention measures, symptoms, testing, and then of course the impacts on social supports, access to healthcare, and emotional well-being. Finally, we're also looking at the prevalence of COVID-19 and testing for antibodies. And I'll be only presenting a portion of that data here today. Next slide. So first, we use purposive sampling to collect a select group of folks that represented the broader population that we have of our young people. So to make sure we had representation across gender identity and race ethnicity. And we had research assistants that contacted our potential respondents that were already enrolled in the R01 to see whether or not they would want to participate in these interviews that were conducted over the phone. So all 40 young people who were contacted successfully by phone did participate in the semi-structured phone interviews, which were conducted at the height of the COVID-19 lockdowns here in the Houston area. Next slide. The interview guide was modified from the once qualitative interview guide, the COVID-19 interview items for vulnerable populations that came out in 2020. It was compiled by the Center for Drug Use and HIV and HCV research. The main probes explored participants' knowledge of COVID-19, changes in housing status, and the ability to adhere to COVID-19 prevention measures, mental health concerns, healthcare utilization, and then also sexual health status. Next slide. A total of 40 young people were participated in this qualitative portion of the study. The majority of respondents indicated that they were housed the night of the interview, meaning that they stayed in a shelter or they were staying with friends, family, or an acquaintance. They also indicated that they were adhering to one or more of the prevention measures, including either social distancing, wearing masks, or washing hands, using hand sanitizer as often as they could. Some of the existing challenges that they already have for being homeless were exacerbated by the pandemic, such as job loss and instability, financial and housing instability, and just overall disruption in being able to meet their basic needs. Youth also talked about coping strategies that emerged as a response to the pandemic stress. These included things like renewal in self-care, connecting with others in their social groups, but then also using drugs and alcohol. Next slide. So another purpose of this study was to really look at the COVID-19 antibodies. So we're enrolling 268 young people to be able to draw that sample and see what's happening when it comes to antibodies. We're also looking at intentions and behaviors related to COVID-19 vaccine diagnosis and symptoms. I won't be presenting the longitudinal data there, but just the cross-sectional data that we have. So as of last month, March of 2022, we had 174 participants who had consented for that one-time blood draw. And so we use plasma was tested using the NI-spike antibodies for IgG to SARS-CoV-2. And that's commercially available kit that we used. And then we used the ELISA test on those samples that came back positive so that we could do an anti-nucleic capsid antibodies to look whether or not the infection was natural or vaccination induced. And then again, we are also collecting data at 3, 6, and 9 months, but that will not be presented here today. Next slide. So the sample was mean age of 22, and the majority identified as African-American or Black. Next slide. There were slightly more males than females, and a smaller percentage of young people who identified as transgender. And about 38% of the sample identified as LGBTQ, and that approximates what we find in a variety of other studies that we've conducted in this area. Next slide. We asked young people where they had stayed last night prior to having the survey. The majority had stayed in a shelter or were temporarily staying with others, either friend, family, home of a boyfriend, girlfriend, sexual partner, and acquaintance. Next slide. About 40% of our participants had received at least one dose of the COVID-19 vaccine, and vaccination rates increased from the time we started in March of 2021 through March of 2022. Very few young people reported any experiencing any COVID-19 symptoms, and fewer, about 10%, suggested that they had reported a diagnosis of COVID-19. Some of the symptoms that we asked young people about were fever, dry cough, shortness of breath, fatigue, loss of smell or taste, isolation, anxiety, and depression. Next slide. 59% of the participants that had a positive IgG test result, they were different based on whether or not they had a self-reported vaccination status. Participants who were vaccinated had higher odds, of course, of testing positive for antibodies. The proportion of young people who tested positive also increased from March of 2021 to March of 2022. We then took the 103 samples of those who had positive IgG tests and conducted an anti-nucleic capsid test. 36 of those, or 37%, had that antibodies were attributed to the occurrence of natural infection. Another 7 had borderline results. So that suggests that the rate of natural infection ranges somewhere between about 37 and 45% of young people. Next slide. And as I mentioned, over this 52-week period that we are currently looking at, you can see that the rates of both antibodies and of vaccination, self-reported vaccinations are increasing. Next slide. So what's great is that we're seeing that we're having some uptake of COVID-19 vaccine. However, it's still fairly low. And even though we're seeing very few young people who are reporting symptoms or a diagnosis of COVID-19, about a third of participants that had positive antibodies can be contributed to a natural infection. So again, we need to continue to have targeted efforts to distribute vaccines to young people who are in these circumstances, whether that's through shelters and drop-in centers. And we also need to consider how we are going to handle sort of sheltering in place strategies for those who do not have a place to shelter. Again, we are continuing to have follow-up with these young people. We'll follow them up every 3 months for the next 12 months. So there'll be more data to come. This is our wonderful team who's been working on this project through all of the challenges that COVID has thrown our way. Very grateful for everybody here. Here's a team of our research assistants and coordinators, and I will stop there.
Terrific. Thank you, Dr. Santamaria. That was a wonderful, interesting presentation. So up next, we have Dr. Captain.
Yes, thank you. So when we saw the call for presentations, the authors of this presentation actually submitted 4 proposals, and the organizers in their wisdom decided that might be a little much. So I combined the 4 presentations into one. So you get really getting 4 for the price of one. Actually, you get 5 for the price of one. I'll show next. Next. So since 2014, we have started the probability-based internet panel called the Understanding America Study at USC. And what this amounts to is that we ask our respondents regularly about a wide area of interest. And then when the pandemic started in March, on March 10, 2020, we started what we call the Understanding Coronavirus in America Study. UCAS, and I'm mentioning this acronym because you will see it a couple of times on the subsequent slides. The first survey we put in the field was on March 10, and it ran between March 10 and 31. And then after that, we reverted to a 2-week frequency. Next. So the way this worked is that every day in the 14-day period, about 450 or so respondents answered our questions. And then after 14 days, the cycle started all over again. And one of the things we did is we posted the descriptive results on our website every night. So you could check the website and see what was changing over time. And altogether, we posted about 3,000, a little less than 3,000 graphs like the one I showed here. And then we continued this until June 2021. And then after that, we reduced the frequency. And now we do the same survey, but only once every 4 months. Next. So an essential part of this is that the making the data available to researchers, because really we wanted as many people use the data as possible. Altogether, we have now collected 31 waves nationally, and then we have actually 57 waves in Los Angeles County. We have close to 200,000 surveys from more than 9,000 respondents. And as you see here, more than 400 research groups around the world have been using the data, and that number is still growing. To make the data useful, we also have linked contextual data so that one can also then link the survey data to, for example, information on local policies, infection rates, etc. So turning to the first topic I want to talk about, this is about protective behavior. As we know, there is a lot of variation in the extent to which people exhibit protective behavior. So what we have done here is we've done a cluster analysis where essentially we put people in 3 buckets from low protective behavior to high protective behavior. And protective behavior is measured by things like whether you attend large gatherings, whether you have people at home that you don't really know very well, how often you wear a mask, etc. And then we want to see what predicts these differences in protective behavior. So we look at individual behavior like social demographics, political affiliation, institutional trust, and health beliefs. And there are contextual issues, the friends and family you have, their opinions, your work environment, the community you're from. Next. So this, in some ways, tells the story, and maybe not very surprising. So green means that you're in the group of highly protected behavior. Red means you're in the group of not a whole lot of protective behavior. And what you see is that older people are more likely to exhibit protective behavior. There's not a whole lot of difference between male and females. Whites are the least protective, if you like. There's not much of a variation by education, but then we see a very stark difference between Democrats and Republicans, and I'll actually talk about this a little more later on. Next. So this tells you something about the predictive power of these various groups of variables. And so the numbers here mean essentially how well you would be doing if you were to aim at predicting where someone is in one of these three buckets, whether they're very protective or less protective, etc. So for example, if the number at the top of one of these bars would be 0.50, then it would simply mean you might as well flip a coin. So if you look at this, you see health beliefs, what people think is important and how they think what's risky for them. That's the most predictive, and then it goes down to the right. Institutional trust is clearly important. Social demographics, of course, explain some of it, and then political affiliation, and then it goes down to the right to work context. Next. So talking about partisanship and political affiliation, I want to look at this a little bit more over time. It has been documented early on, also partly based on our data, that Democrats perceive a greater risk of COVID-19 than Republicans. But the question is, how did this change over time? And also, how did this change when vaccines became available? Next. So this is just a graph that looks at how risky people thought certain activities were. So we distinguish 13 activities like going to a supermarket, going to a bar, meeting other people, etc. And then we take an average for the 13 activities, and the scale runs from 1 to 4. And the blue line is what you find if you look at just over time how risky Democrats on average thought these activities were. And then the red line is how risky Republicans thought these activities were on average. And you see that it's going down for both, so they both become less concerned about activities. But first of all, Democrats are indeed much more likely to think that something is risky, and it also is not going down as much as among Republicans. Now, in addition to asking about the riskiness of activities, we also have a number of straight questions where we simply ask, what's the probability that you'll get infected? What's the probability that you'll get sick if you get infected, etc.? And that's the second check mark here. And there we actually don't see much of a change over time. So there is a difference. Republicans think there's less of a risk than Democrats, but it doesn't change much over time. Next. So this is if you look at the effect of vaccination. So early on, of course, no one was vaccinated. And again, you see that the probability of getting sick is higher for Democrats than for, the perceived probability is higher for Democrats than for Republicans. But then when they get vaccinated, you see that it's really close and it's no longer significantly different. The same is true for the risk of hospitalization. You also see that difference is significant once they get vaccinated. Next. And then finally, the same for the risk of death. For death, again, you see that at the end, there isn't really a significant difference anymore between Democrats and Republicans, how they think about the probability of dying of COVID once they are vaccinated. Next. So, of course, if it's the case that vaccination reduces your perceived risk of bad things happening, then you would expect that this also means that your mental health probably gets better. So what we have done from the beginning, we have collected data for the PHQ-4. And as many of you know, this is just a very simple scale that asks people about over the past 14 days, whether they felt anxious, whether they felt depressed, whether they were worrying, and whether there were days of very little interest. And we look at that, and then we combine that with what we know with vaccination status of our panel members over time. Next. So we want to look at whether vaccination actually helps reducing mental distress. Now, people who get vaccinated at some point and those who never get vaccinated are obviously not the same. So if you look at the graph, you see the light blue, these are the people who never get vaccinated during the observation period in our panel. And the black are the people who do get vaccinated at some point. You see the patterns over time are very similar, but you do see that the mental distress is higher for those who choose never to get vaccinated. Nevertheless, if you sort of look at it closely, you get the sense that at the end, you see this dashed line, that at the end, the gap may be widening a little bit between those people who don't get vaccinated and those people who do. Now, to get a better view of that, let's look at the next slide. Next. So this changes the scale. So the 0 is here is the moment that people get vaccinated, and then to the left, you have periods before people were vaccinated. On the right, you have people who did get vaccinated, and now you see a clear difference. And actually, if you do analysis, you find there is a highly significant effect of being vaccinated on a reduction in mental distress. Next. But you see, moreover, that, and probably one would sort of expect that if you divide a sample in those people who exhibited mild mental distress and then moderate and severe, then you see the effect for those people with mild mental distress. Really, the effect isn't very large. It's only 4% of the baseline level. But if you go to the bottom, you see that for those people who exhibited severe mental distress, there actually the vaccination reduces their the level of the mental distress by 20%. Next. Okay, and then finally, of course, one of the things that was very marked about the pandemic is how it changes work patterns. And today's conference is in some ways a reflection on that, and because people started working from home much more than they did before. So we're looking at that in somewhat more detail. We look at the ability to work from home, whether people like working from home. And then we also want to look a little bit more about job satisfaction and everything else it entails. Next. So these pictures are by now familiar. I think many people have documented these patterns. So if you look at the left graph, you see that there is a strong gradient with education. People with college or more are much more likely to be able to work from home than, for example, with lower education. Similarly, by income, the higher the income, the more likely it is that respondents will say that their job actually allows them to work from home. If you go to the right graph, you also see that I would say expected distinction by job type, occupation type. People in business and financial sectors, in computers, mathematics, offices, admin support, they're all more likely to say they can work from home. On the other hand, if you're in healthcare or you're in construction, then you're less likely to say that you're able to work from home. Next. So the thing of interest here is really, what people want to do, and that's relevant for now. It's also relevant going forward to sort of anticipate what may happen. So the top graph here shows how often people would like to work from home. So if you look at the first very long bar, it shows you that 32.9% of the respondents say they would actually like to work from home all the time, 5 days per week or more. And if you go down, then you see that it's really only 14% that says they never want to work from home. Now, the question is, how does this match what's actually possible? So if you look at the bottom graph, you see that how many days a week people expect to work from home. And one assumes that means that they think this is possible given what their employer tells them. These numbers are lower. So, and if you look at the bottom summary, you find that about half expect that what they want to do will actually be in line with what the employer will allow them to do. But then 38% would like to work more from home than they expect to be able to. And this may be both due to the kind of job they have, or it may just be maybe a result of restrictions that are imposed by their employer. Next. So, of course, if people like to work from home more, then an obvious question is, are they actually willing to give up some money for that? That's a typical economist question. So we ask people, what percent of your paycheck would you be able to give up if you could reduce the number of days that you're not working from home by 1 day a week? And you see about half say, well, I really don't want to give up any money. So that's 46.9%. But if you go down, you see that 10.4% of the sample says that they would even be willing to give up something like 15%. Now, if you go to the right graph, now we're not asking about 1 day a week. Now we ask about working from home the whole week. And other numbers actually get a little bigger. So for example, looking at the bottom again, you said that 50, you see about 15%, 40.8% of the sample says they would be willing to give up about 15% of the paycheck if they could work from home all the time going forward. Next. So of course, if you're willing to give up money, then also it tells you something about the happiness that you would experience when you work from home versus working at the workplace. And indeed, if you ask people about their job satisfaction, you find that the job satisfaction is about 12 percentage points lower for workers who are not able to work from home relative to those who are actually able to work from home, and also can work from home as much as they would actually prefer to do. And you find a similar difference between people who would like to work from home more relative to those who actually can work from home as much as they like. And all of that has, of course, consequences, for example, for retention. If you look at the graph on the right, the yellow orange bars refer to people who cannot work from home, and then the green bars refer to people who can work from home. And what you see is that the yellow bars are all higher, and the yellow bars then tell us that the fraction of individuals who are currently looking for a new job is higher among those who cannot work from home than among those who can work from home. So this ends my my little tour of some of the things we have done. You know, as I said, there's more than 400 groups using the data, but there's always room for more. So I certainly invite you to check out our website and see whether data that you want to use for your own analysis. Thank you.
Thank you, Dr. Kaptein. That was a terrific presentation. Up next, we have Drs. McReynolds and Amsel.
Hi. So this is going to be a talk about altruistic social decision-making and vaccine acceptance or rejection. Next slide, please. So the question that we had was, is there a role for altruism in U.S. college students' vaccine acceptance? And the reason this is important is because we know that relatively shortly into the pandemic, we did have effective vaccines, but we also ran into immediately a behavioral problem that vaccine uptake seemed to be problematic. And there's an extensive literature on what the problems people had or discussed in regard to whether they were willing to take vaccines or not. Our group, which is a psychiatric epidemiology group, focuses on children and youth, and also on families, but we realized that the college period of time among people is a very important time for understanding COVID because it's so transitional. If you're going from adolescence to becoming an adult, it's a very difficult time in ordinary circumstances and very, very disruptive to COVID. So we were very interested in the college students and their way of interacting with COVID. In particular, the college students themselves were at less risk for being really seriously harmed by COVID. And we wondered, therefore, how did that affect their vaccine acceptance? Because their vaccine taking might really be more about other people and protecting other people. So we were doing an online COVID survey, a comprehensive online survey, and we included aspects of this vaccine hesitancy and of the trying to measure altruism. Next slide, please. So our online survey, we were very fortunate to have the AAC&U, which is the largest national association of colleges, and they helped us to reach out to colleges, and the colleges themselves who collaborated with us, which was all their members, reached out with a school-wide email. And then subsequently, we also had a social media outreach. So we had a good outreach to lots of students. To participate, the students had to be enrolled in a college, be 18 years old. They had to provide consent and agree, of course, to the HIPAA authorizations. Now, we were very sensitive to the fact that these students might be vulnerable in multiple ways and vulnerable to our questions and might be experiencing difficulties. So we made sure that every one of the participants had access to a great deal of health behavioral resources. And for people who expressed any kind of suicidality, we had a contract with a national organization that would be able to reach out to them and support them if they were in a suicidal crisis. So we were very sensitive to that. Now, not all of the respondents gave us their contact information, but it turned out that most of them did, allowing us to follow them up later, and we are hoping to follow them up later with grants that we have submitted. Next. So what did we look for? And I want to first acknowledge the two speakers who came before me, because they set up my talk so beautifully by laying out so many of the issues that, of course, we're all facing together in this COVID crisis. And a lot of their survey questions overlap with ours. Using a technique I'll describe in a minute, we were able to do a relatively extensive online survey, because that's always the trade-off between how many questions you can ask versus how many people are willing to go through the survey. And I'll discuss our methodology in a moment. But here are the areas we wanted to look at. Exposure to COVID, what are your experiences returning COVID? What are your related academic experiences? In other words, were there gaps in semesters? Did you miss classes? Were you in and out of dorms? Those kinds of issues. Also, daily and life living, where you lived, were you hunkered down with friends or not? Did you lose your job? Those kinds of things. And that's the employment and finance questions about your job, family job, whether family people lost job, whether money was lost. We know that financial hardship to the point of food insecurity can become a very, very big issue. We also ask people about health, and that is their actual health, but also their mental health and also their health behaviors, their protective behaviors and aspects, which we've already heard a good deal about. And finally, and this was our most innovative part, is we are a group that's very interested in decision-making and the relationship of decision-making to psychiatry, an area that's come to be known as computational psychiatry or decision psychiatry. And so we were very interested in asking people about their decision-making processes. And one of the important things about decision-making process, unlike many psychiatric questionnaires, is it doesn't involve you making an evaluation of yourself, but in decision-making tasks, you do a behavior on the task, and then we can ascertain things about you. So it doesn't require that filtering through self-perception. Next slide. So here's the planned missing data design, which I alluded to a moment ago. And this is what allows us to ask more questions than we could otherwise. And the idea here is that you break your group into several panels, and not everybody gets every question. So there's a sophisticated overlapping of a core of questions and then additional questions that people get in an overlapping fashion, so that we can impute results when there is purposeful missing data. We can impute results, and at the end we can have a larger sample, especially in areas like this, which is a discovery areas. This can be a very effective technique for increasing the size of your sample by shortening the actual time that people need to spend on the questionnaire, and nevertheless you can get a lot of people answering a lot of questions, which is the goal. Next slide, please. So who are our participants in the end? Interestingly, it was largely skewed towards females. They were between 18 and 24, as we expected. They were distributed across the academic years. As far as the race and ethnicity, we're 53% white, 18% Hispanic, and 10% Asian. Those are not bad estimates, although the Asian a little bit low within college representation, but not terrible estimates. We were low in the Black and African American representation on the survey for reasons that were not completely clear, but we're looking into right now. In terms of attendance, 19% were attending community college. We were very happy about that, because the community college students are often ignored. 83% were full-time students, and most of the students who were represented were able to complete significant parts of the survey. Next slide. So I mentioned that decision-making was an important part of this, and what were our decision-making what were our decision-making aspects? Well, we used something called the ultimatum game. And the goal in the ultimatum game is to characterize how different people act in a game situation explicitly by their behaviors. We also used something called the moral foundations questionnaire, which is a self-report, but it doesn't ask you directly, you know, are you a good person? Are you altruistic? But indirectly captures that aspect. Next slide. So we understand the ultimatum game, and there are multiple ways of understanding the ultimatum game. And it's been around since 1961, and there are multiple ways of understanding it. But the way it works is that we give a proposer $100, and that proposer then says, I will share with a responder, and I will share this amount. And then the responder gets to agree or disagree with the sharing scheme. If he agrees, they both get that thing. If he disagrees, everybody loses everything. So that's why it's called an ultimatum game, because if the responder rejects it, then no one gets anything. So next slide. So why is it a measure of altruism? Well, let's say that there's an offer of 20 and the proposer says, I offer to give you 20 and keep 80. Well, it's a kind of a hard decision to make. But as our understanding is that those responders, those people who respond to this, who are willing to take the less amount rather than have everybody have nothing, they say, I'm willing to take less of the pie to make sure that everybody gets something. And we understand that as a behavioral manifestation of a kind of social altruism, because they're maximizing utility for the whole group, meaning the both of them, instead of focusing on whether their own share was equal or not. So that's why we see it as a measure of altruism, but it's an implicit measure. It certainly doesn't ask a person about their altruism. Next slide. For those of you who are familiar with game theory trees, this is the way it looks in a game theory tree. The first proposer proposes, and the second proposer then responds, and then at the bottom are what would be the outcome distributions of the values. And for those of you who are familiar with those kinds of trees, this is intuitive. Otherwise, you can ignore that. Next, please. The Moral Foundations questionnaire asks people about their relative values, and it's been used to predict political affiliation and things of that nature, which we've already heard about, interestingly. It talks about harm, fairness, in-group, authority, and purity. And it asks how much these different potential value systems are more or less important to you. We focused on the fairness subscale, which asks questions about, do I think the most important thing in laws is that everybody's treated fairly? And it asks other kinds of questions which capture the importance to yourself of fairness. So next slide. So after the imputed logistic regression, again, as I said, so we had the three groups and we imputed it. I'll draw your attention to the very bottom two rows, which is to say the Moral Foundations questionnaire had an adjusted odds ratio of 1.15, significantly, for predicting that you would either had or are willing to take a vaccine. And interestingly, in the ultimatum game, if you accepted a quote unquote unfair, i.e. any kind of offer that was less than 50-50, if you accepted that, in other words, you took the altruistic positions, you had an odds ratio of 2.62 of being willing to or already having taken the vaccine. Next slide. So I've already somewhat summarized these. By 2021, most of the students had completed the survey. And again, if I take you to the bottom few lines here, we saw from the data that accepting vaccine was associated with an increased odds ratio on the fairness subscale, and as well, with an increased odds ratio of taking the vaccine. And again, if you behaved altruistically on the ultimatum game, then you were twice as likely, 2.5 times more likely to be a vaccine acceptor, which again, for college students who themselves aren't under mortality risk, we think makes a lot of sense, and that their vaccine acceptance had to do with their thinking about others' well-being as much as their own. Next slide, please. I've run through much of this discussions, but again, the main points here is that the self-reporting unfairness worked, and the ultimatum game worked to demonstrate that people were willing to take the vaccine. But we also believe that we solved the problem in this, which is the problem was the measurement of altruism. Did we capture measurements of altruism? And since these things worked in tandem, these two different kinds of measures, a self-report and a behavioral report, we felt that we somehow were able to triangulate and capture this notion of altruism, this notion of looking towards the other as it related to vaccine acceptance. So those results to us were a terrific beginning, especially for our ongoing work in how decision-making, individual decision-making and differences in decision-making are going to affect your COVID's behavior. Next slide. I want to thank my partners in my group, especially my partner, Larkin McReynolds, who is a partner with me in all of this. The head of our team was Christina Hoven, and the Global Psychiatric Epidemiology Group at Columbia, who did this research with us. And thank you so much for your attention.
Thank you, Dr. Emsel. That was great. Next, we have Dr. Kim.
I'll be presenting on mechanisms of psychosocial precursors and vaccine decisions for adolescents and Mexican immigrant families. And these are Mexican immigrant families in the central Texas area or near the Austin area. Next. So our focus of this project is on Mexican immigrants. And as you can see here, the Hispanic or Latinx population is growing, one of the fastest growing minority groups in the US. Next. And as we probably all know, when we look at the hospitalization rates by race and ethnicity, Hispanic or Latino groups are overrepresented relative to non-Hispanic whites. Next. So our conceptual model was trying to test how, this is a longitudinal study. We started the data collection with our adolescent participants when they were around age 12 in middle school. And that's what W1 or wave 1 represents. And we followed them at wave 2 and 3. Wave 2 was about a year later. And then wave 3 was around 3 years after that. And then wave 4 is our current data collection. And that's the funding that we received from NIH to do the COVID-19 supplemental grant. And so we measure socioeconomic status at both wave 1 and 4, and cultural stressors such as discriminatory experiences, feeling like a foreigner, or what we call cultural stress collectively at wave 1 and 4 as well. And we wanted to know if socioeconomic status and cultural stressors, or what we call collectively psychosocial stressors, may relate to wave 4, how they perceive what they perceive as barriers to getting the COVID-19 vaccine, and whether getting the COVID-19 vaccine is related to less positive attitudes towards getting the COVID-19 vaccine, and whether that in turn would predict two outcomes: their motivation for getting the vaccine and whether they indeed got the vaccine. Next. So this is a 4-wave longitudinal study, as I mentioned. At wave 1, we started with about 604 adolescents, and that's the sample size at wave 2 and 3. And we're currently in data collection at wave 4, and we have about 116 adolescents who have provided data thus far, which is, and those are the slides, the results I'm presenting today. Next. And so our measure of socioeconomic status, family economic stress, is a measure that is comprised of feeling conflicts about money, such as did your parents argue with each other about not having enough money? And also in terms of worrying about money. For example, how much of a problem did your family have because your parents did not have enough money to buy things your family needs or wants? In addition to socioeconomic status, we also asked adolescents when they were in middle school, what's the highest level of education you expect to achieve in school, or educational expectations? Next. In terms of cultural stressors, we have measures of daily discrimination, which is the common David Williams scale. And we also adapted that to get at ethnic discrimination, where we ask questions like, I'm treated with less respect than other people because I'm Mexican. And then we also had a measure of foreigner stress with items such as, because of how I speak, people sometimes assume I'm not a US American. Next. And we also have a measure of barriers to getting the vaccine, such as I'm confident in my ability to find information about the COVID-19 vaccine, which is reverse coded. Information about the COVID-19 vaccine is easy to access, and whether getting the COVID-19 is difficult because I'm Mexican. And then positive attitudes to vaccines, such as COVID-19 vaccine can be trusted, it's beneficial to take the vaccine, or that the vaccine is safe. Next. And so our two outcome variables was vaccine motivation, where they were whether the adolescents felt motivated to take it, and their vaccine status, whether they have received the COVID-19 vaccine. So going to our results, next slide. We first looked at discrimination experiences or cultural stressors to see if that may be related to either vaccine motivation or vaccine status as the outcome. And we found that there were some cross-sectional findings where feeling high levels of discrimination, ethnic discrimination, or foreigner stress ultimately related to vaccine motivation through two mediating factors: barriers to vaccine, relating to positive attitudes, or relating to lower positive attitudes towards the vaccine, which in turn related to higher vaccine motivation. Next, we then try to also predict vaccine status, and it also related to positive vaccine status. But wave one, or when they were feeling cultural stressors as middle schoolers, did not predict vaccine status nor vaccine motivation. Next slide. We also looked at family stressors, the economic stress measures of economic conflict, as well as worrying about finances. And interestingly, how adolescents felt about economic stressors early, as early adolescents in middle school predicted lower positive attitudes towards the vaccine, and in turn related to positive vaccine motivation. Next. And when we looked at wave 4 family economic stress, we also saw that it predicted vaccine status through the mediating factors of barriers to vaccine and positive attitudes towards the vaccine. Next slide. We then looked at whether educational expectations may be related to vaccine motivation and status, and we found that higher levels of educational expectations related to indirectly related to vaccine motivation through barriers to vaccine and positive attitudes towards the vaccine. Next. Next. Next slide. Oh, sorry. Okay. Okay, go ahead and next slide. Okay, so some of the challenges we faced in doing this study was that data were collected in different times at different COVID-19 stages, but we were able to contribute to the literature by looking at psychosocial risk factors that may influence vaccine motivation as well as decision. And we're hoping that in the future, we'll be able to associate COVID-19 cases with adolescents' experiences related to the COVID-19 vaccine. And next. Those are all my slides. I do have, I'll be open to answering any of your questions.
Terrific. Thank you so much, Dr. Kim. And thanks to all the presenters. That was just such a wonderfully informative and diverse set of talks. And I want to thank you as well for all the questions that I see being answered in the chat. That's incredibly helpful. There are a few outstanding ones, and we have, I think, 7 minutes for Q&A. So I'm going to read out the ones that I have not seen answers to. The first is from Aaron Scherer. It is for Dr. Amsel. The question is, the ultimatum game requires the participant to believe that they're actually playing the game with another person. How is this done in your study?
Yes, so I would have to push back on the assumption there. There are different forms of the ultimatum game, and especially when you're doing an ultimatum game in which you're not looking at one individual, but you're comparing different individuals. As in our case, it is a hypothetical. How do you think you would respond? How do you believe you would respond to this? So when I'm comparing different individuals across a large group in terms of what they believe their hypothetical would be, what the research has shown is people sort of do put this is work related to how decision-making is done in imagination. And people do put themselves in that. And so it does become a reasonably good, of course, it's always best to have actual money and actual people going on. But in this context, it does become a reasonably good approximation of how people might behave on the actual ultimatum game. So under the circumstances, that's what we were able to do. And we believe that it has good face validity for the concept.
Great, thank you. The next question is for Dr. Kim. And the question is, were children in your study foreign-born too, or only their parents needed to be immigrants to be eligible?
So in our study, only the parents needed to be immigrants. When we look at the adolescent samples, 75% of them were born in the US and 25% of them were foreign-born.
Great, thank you so much. And then we have a question that is addressed to Dr. Amsel and Dr. Kim. Did concerns related to the vaccine and fertility come up? If so, how did your team address those concerns? Thank you.
So I'll start and say no. I defer to the other speaker. We didn't look into fertility in this part of the analysis.
Yeah,
Thank
so in our study, we didn't examine fertility either. And when it came to vaccines, one of the things that we did notice is that we were really surprised at there were such stark when we looked at their educational trajectory. So those adolescents who ended up going to college were more likely to be vaccinated. And those who didn't end up going to universities and ended up going to community college or decided to go in the workforce, most of them didn't end up getting the vaccine. But we didn't do a qualitative component to our study. Everything was quantitative. So, and we were really shocked that, many of them didn't believe that the vaccine was safe, especially the ones who decided not to do it. And especially were the ones who didn't go to college, the ones who ended up just going to the workforce or finished their education in high school.
Great, thank you for the answer. And we had another question just come in, also for Dr. Kim. Did you examine in some ways whether the migration status of the parents influences children's perception of barriers, attitudes, or vaccination status?
So Dr. Martinez Donate, in order for participants to qualify for the study, the parents had to be immigrants. So like literally 100% of the parents are immigrants. So we can't test migration status of parents because all the parents are immigrants themselves.
Thank you for that. Thank you for clarifying. We have about 3 more minutes. If there are any other questions that folks want to put in the chat, I'd be glad to read them. And Dr. Martinez Donate clarified she meant whether they were permanent residents or a more vulnerable status.
Okay.
Or naturalized.
Yeah, that's a great point. We don't have a question asking about their residency status. So we only ask if they're a US citizen or not, but we don't separate it out by permanent status or undocumented or naturalized. So unfortunately, even though the question you asked sounds fantastic, I wouldn't be able to actually do that analysis. I see Dr. Eliseo Perez-Table. He says, did collect data on level of misinformation, access, or exposure? We did not. Sorry about that.
Thank you for answering that directly. I appreciate it.
Sure.
And then there's a question, I believe this is for Dr. Kaptein. How were the response rates for the Understanding America study during COVID?
They were really not different from other times, I think. The people have voiced concern that the response rates might be lower, but if anything, I would say they certainly were at the same level as before. And there's also, since it's all online, there was also no particular reason why response rates would be different.
Great, thank you for that. And we have time for maybe one more. If anyone has them.
Dr. Amsel here, I would just like to thank the organizers for putting us together. This was such a wonderful group to have these things together. The study supported each other so beautifully. Thank you for that organizing brilliance.
On that note, I think we can thank you so much for your lovely comments, and thank you for a wonderful first session. Before we take a quick break, 10-minute break, the next session is going to be parallel sessions. So right there we go. So if you want to take a look at this slide, so you can choose which session you want to choose. I believe you'll have a pop-up box come up on your screen, and then you can select which session to join at about 1:39, I believe. Let's take a quick 10-minute break. We'll be back at 1:39 to select your session, and then we'll get started with the next panel. Welcome back to the main room. Thank you all for a wonderful day, and apologies for the glitches, and much appreciation for the patience during the glitches. I guess we have to remember that glitches happen in person or away from or not face to face. So, Dr. Parastavlo, would you be so kind as to close us out for the day before we have some networking sessions?
Absolutely. I want to thank, first of all, the organizers, the co-leads on this social behavioral economic issues of COVID-19 initiative, which we kind of stood it up 2 years ago, and in response to the crisis. And this is not just about the therapeutics and development of drugs and vaccines and the biological mechanisms, but there were a lot of other things going on, and obviously just feeling the energy and listening to some of the presentations. I wasn't able to be here or be in 2 rooms at the same time. I was really quite impressed and appreciative of all the efforts you have done. And even though we may not have the sort of the carve out support that other processes may have, and of course NIH appropriations are always unknown to us until they happen. Clearly, this has changed and this has impacted us in many ways, and we'll need to continue in some format. I was pleased to hear about the interventions. And the thinking about the interventions in the first breakout. I particularly think that the focus on sort of the presentation on the sort of the one shot intervention for adolescents might really be a generalizable approach to issues for many individuals, not just adolescents. I was impressed in that study that Dr. Schleider, I think, presented, that 80% of the participants were sexual and gender minorities. That's something that's remarkable, and you weren't necessarily expecting that. Similarly, looking at vulnerable, marginalized groups, as I saw Dr. Kim, Mexican adolescents, Mexican American adolescents whose parents are immigrants. The question on documentation you couldn't answer, but I thought where people get information is becoming really important, and accessing the internet for good stuff also means bad stuff, and there's a lot of malicious misinformation out there that we have to get better at how to counter. That's one of the adverse lessons I got from the pandemic, is we developed the mRNA vaccine, we got it out, but we lost we did not anticipate the communication battle that we lost. I don't want to say that it's over, because this is an area that we really do need to emphasize a lot more. And there were a number of other relevant presentations. And then I joined the mortality session, and although I only came in partway through, Cecile's analysis, which I had known about or read about, was, I think, consistent with everything we've seen. Other analyses coming out of NIH intramural program showed almost 500,000 excess deaths in 2020. 3/4 were due to COVID. This is based on death certificate from the CDC, the preliminary release, and that showing that diabetes and Alzheimer's disease and cardiovascular disease all were associated with increased risk of excess deaths, I think was very illustrative. And then the issue with cancer caused a lot of exchanges in the chat and in the breakout. And I think that Dr. Sharpless was saying how many excess deaths are going to be from cancer in 10 years as a consequence of COVID, in either delayed diagnosis due to missing screening or missing out on earlier diagnosis that may have led to a cure. And yes, that's going to take a much longer time to evaluate that, and we'll have to see how that goes. I thought that doing more in the healthcare context with a particular condition is important. The work on ADRD related mortality from nursing homes, I think, was especially illustrative in that way. I did notice in the charts that the Latino, Black, and Asians, well, maybe not, I don't remember if Asians were included, without ADRD from the nursing homes, had the same mortality as whites with ADRD. So there was a disparity there on the basis of race, with the much higher rates of ratios of mortality for those with ADRD, and I think that was and the data on economic modeling, if I could ever completely get my head around it, would take a long time. But I think gleaming from that discussion and from the presentation, a sense that the lockdown approach to respond to the pandemic may not have been very effective in many ways, although obviously if you locks everybody up and doesn't allow people to leave the building, that could work, as we have seen that deployed in perhaps in China primarily, but also maybe in the initial phases of the pandemic in Italy, and to less rigorous extent in New York City. But it clearly has other impacts. And if it was a 2 or 3 week lockdown, people might have tolerated it. But when we went into several months, it clearly was being counterproductive. And there was bad for economic activity. While masks were not, and masks were simply required, it certainly does have evidence of benefit, and yet we have now reached a point where it became politicized. People are not doing it, or the mandates have been completely lifted. And finally, just the presentation on suicide. I've been hearing this from Josh Gordon, and clearly suicide rates have gone down, and perhaps it's hard to compare the pandemic to anything. The 9/11 event was horrific, and it was localized, and it affected our national psyche, but it wasn't a risk for everyone in the world as the pandemic was. And the impacts of economic recessions were cited, but yet we saw a plunge in employment in March of 2020 that had been unparalleled. There was intense intervention on the part of the federal government to address some of that. There was a recovery that followed. It wasn't as profound a depression of economic activity as some might have been concerned about. But this is just incredibly relevant information. And I think we'll learn a lot more as we are able to digest and analyze more of the data as it gets out. And it's not over. The pandemic is not going away. In fact, cases are going up, and we're in a different phase as we speak. So I want to thank everyone again. I think Erica and John, whom I saw here, but also the other co-leads of the interventions work group of the SBE initiative, Susan Borja, Jennifer Alvidres, and the many NIH staff who have worked diligently on this for the last 2 years. Thank you, Erica.
Thank you so much for that excellent closing. I really appreciate it, Dr. Parasava. So our talks are over for the day. We want to thank you for your participation. I want to remind you that we are reconvening tomorrow at noon Eastern time for the second half of our event. We have 21 more presentations. We will most definitely be in touch with all of you about future activities, and we'll request any feedback from the event or ideas that you'd like to share. And some point in the near future, there will be an SBE website that will feature a lot of the research that you've heard about today and we'll hear about tomorrow. And while the talks are over, we do now have 2 networking opportunities for you, as you can see here on the screen. It says, again, a track 1 and a track 2 kind of opportunity. The first one is measuring policy and will be led by the consortium. And the second one is the impact on emerging adults that will be held at the same time. So I believe that we will be given the option right about now-ish to join 1 or 2 of the groups if you'd like to, and in 5 minutes. Is that what in 5 minutes? So take a quick break and come back and network with us. This is a informal opportunity to chat with your colleagues and to come up with some great new ideas. So we're looking forward to talking with you in the next 45 minutes. Thank you.